Srinath sir, you are on mute.
I'm unmuted myself.
Okay. Yeah, we can start.
Great. Good evening, friends. It's my pleasure to introduce one of the best speakers of this webinar series. This is none other than one of my closest friends, Professor Dr. M Rajadurai, who has done his MBBS, MD Anesthesiology, Fellowship in Emergency Medicine, FCCC, and FLM. Is currently the Senior Consultant, Head of the Emergency Department at Emergency and Critical Care Department at Apollo KH Hospitals, Melvisharam, Vellore, India. Is a Program Director of Academics at KH Institute of Medical Sciences, Vellore, India. Is the current National Secretary for Society for Emergency Medicine, India, and also the Regional Director for OSRIS, Australia. His achievements are many to be told. Few are the gold medalist and university topper for MD Anesthesiology. Is a topper in Fellowship in Emergency Medicine, Fellowship holder in Emergency Medicine, Critical Care and Legal Medicine. He is also the recognized teacher for MD Emergency Medicine and has a rich experience of over 19 years. He has also been as the National Vice President for South Zone for Society and also the State Vice President for Tamil Nadu chapter. He was instrumental in 2 Guinness records, which I have to mention, and I keep mentioning this, which is a proud to be as an Indian and to be associated with such a great person. He had an intention to do a Guinness World Record for CPR training, and almost 40,000 people were being trained on that one particular day, which became a Guinness record, and also relay CPR with more than 2,000 people doing the relay CPR relentlessly for more than 48 hours. That is one of the great achievements, and it's proud for an Indian to be in that position. And he is also empaneled as the assessor for QI emergency medicine, and he has conducted the first international disaster management conclave in India and has multiple publications, several awards. And apart from this, he has also written textbooks on ventilation, and where we are going to listen today on the ventilator management. And also one more book which was launched in the recent emergency medicine conference, the 25th year of SEMI, the ultrasound. He has dedicated these 2 books for Society for Emergency Medicine India, and it is available online also. So that is how it's very important to hear from such a great person regarding the management of ventilation, mechanical ventilation in the emergency department. So over to you, Dr. Rajadurai. It's a pleasure to be associated here. And I also thank the Yashoda Group of Hospitals for allowing us to conduct the weekly webinars on emergency medicine, which is important for residents across the world. So thank you, Dr. Rajadurai, for accepting. Please go ahead.
Thank you, Dr. Srinath. Good evening to one and all. Good day to one and all present here. Once again, I wish to express my immense gratitude and heartfelt thanks to Team Yashoda for the fine opportunity and for the opportunity today to speak as their esteemed speaker in their webinar series. Always expressing and thankful to Dr. Srinath, my dear friend and guide philosopher. I can include all the words to Srinath in the end for his relentless help and service, not only to me, to the entire community of emergency physicians. I take this opportunity to thank Team ER and all members of Yashoda for this wonderful opportunity. Thanks to all the listeners for patient listening. Once again, truly delighted to be part of this academic extravaganza. Today, I'm going to talk about, can you do the screen sharing?
Yes.
So today I'm going to talk about some basics on initiation and modes of a ventilator. In short, about mechanical ventilation in the emergency room setting. In a perspective slightly different from what we usually hear and talk. As usual, I'll try to keep this talk crisp and convey the salient points for your practice with mechanical ventilation in emergency medicine. Is this topic important? Probably if you would have heard about this topic before COVID, not many would have raised their hands and said that mechanical ventilation is very, very important for emergency patient, because of the fact that we never do a long-term ventilation for a patient in the emergency department. So we try to stabilize the patient and try to shift the patient out of our emergency to the critical care unit who requires mechanical ventilation for a longer time. So max, we will be ventilating a patient till stabilization, till radiological investigations. But during the COVID, to be more precise, during the second wave of COVID, we torrentially faced a different scenario in our lifetime, which I do not know whether we are going to face it again, but that has exposed a lot of things. And that has, in fact, made me to write a book on mechanical ventilation for emergency patients, which was successfully launched in the MCon 2022 at Trivandrum. And once again, thanks to Dr. Srinath for appreciating the idea and bringing out the textbook. And in fact, giving the textbook along with the delegate kit to all the people, all the delegates, all the faculties during MCon 2023. So we happen to witness a relatively longer time of patients on mechanical ventilation in ER, that too with a very bad lens during the second wave of the pandemic, which is a clear example that our skill set and knowledge on mechanical ventilation further needs to be armored. So answer to the slide, is this topic important for emergency physicians? Definitely a big yes. You need to have a good knowledge, no more only intensivist or anesthetist or whoever is practicing in critical care should know about mechanical ventilation. That is a myth, no more should be practiced. Emergency physician, like any other topic like airway management or trauma management, even or ultrasound, even emergency physician should know about in detail about mechanical ventilation to handle such patients in the emergency department. Of course, the long objectives would be to talk a little bit about the basics, bit of history with regards to mechanical ventilation, few definitions and initiation of mechanical ventilations, including variables, etc. Of course, the short objective would be to save lives, as usual. So these are all some of the references which I have taken from to build this PowerPoint presentation to present in front of the esteemed audience like you all. And most of the slides will have a reference material too at the end of the content where you can note down for further references. Right. So as I promised, only a little bit of history with regards to mechanical ventilation. I think it is a pandemic that is creating the need for innovation and discoveries in healthcare. And yes, during the 19th century, during the crisis of polio, the negative pressure ventilation came into existence. And from 1950s to the present, the positive pressure ventilation is making a lot of progress in areas of ventilation as well as ventilators with regards to substantial development and innovations. Present times, I'm sure everybody would have seen, we have advanced machines for mechanical ventilation, which even uses artificial intelligence, which advises us when to do a weaning and tell us how to troubleshoot a ventilatory problem and gives us a lot of solutions for the same. Of course, our experience with such advanced mechanical ventilation, though scientifically is not very proven and not very taken well by the intensivist like us, but still to make you all aware that the progress in the field of mechanical ventilation is very gradual and in fact it is still progressing. So this is about the body enclosing boxes from 1864, iron lung spirospore in 1876, and pneumatic chambers where you can see few pictures. I never had a real-time picture of the same. Of course, I happened to learn about a patient by name Paul who lived for over 20 years with negative pressure ventilation. I even saw a photograph. I'm not sure whether in this present era, and I have to believe those things. But this is how the negative pressure ventilation saved lives during the time of polio and after that, before positive pressure ventilation came into existence. It was progressing and progressing. and a paradigm shift from controlled ventilation to partial pressure ventilation support, and then to pressure support ventilation happened from 80s to 90s. So this is an important developmental stages with regards to mechanical ventilation. So before we go on further, I would like to have the residents to know about few important definitions, which is a must before I go through a few of the slides in my presentation. So what is a mechanical breath? Basic unit of mechanical ventilation is called as the mechanical breath. In other words, breath released through a ventilator system. So series of such mechanical breaths is called as mechanical ventilations, and mechanical breath depends on the combination of variables. What is variables? I'll come to that. So most of us will, arrive at dealing a patient or treating a patient with fixed ventilatory mode, because many of us think that ventilation mode is the most important component of mechanical ventilation. And before even we see a patient, when we hear that patient is intubated or patient has come with breathing difficulty, we will come with a preset mind that we need to put the ventilation mode accordingly. So as I told, selecting a mode is one of the many important issues in mechanical ventilation. It is not the only issue in mechanical ventilation. So please be clear with this. Ideally, a mode to be decided, as it has been enlisted there in the slide, a mode to be decided based on the patient, considering the primary disease, lung dynamics and other complications, clinicians, that is you, the emergency physician, based on her expertise, the available resources, support system, and the machine, how advanced or how basic your machine is. So based on these three combinations, your mechanical ventilation therapy should be based on. So do not jump into a fixed ventilatory mode before you actually see a patient. Right. So how do you initiate mechanical ventilation? So these are all few points which we need to consider before we set up a mechanical ventilation for a patient. First and foremost is the indication. Before we go on to the indication, I would like to make the residents very clear of the fact that the importance of airway, because hypoxia kills a patient faster than any other reasons. And in advanced cardiac life support, which usually will be the day one class for most of the residents, including me. So the most important and the first reversible cause is hypoxia and hypovolemia. Out of that, hypoxia is the first and foremost. Like how, the previous times, like how a patient, as soon as a patient enters into the emergency department, usually they'll administer oxygen because they think that is the most important thing, which is partially true, but we cannot be doing it unscientifically. We need to understand oxygen is also a drug and we need to correct it when there is evidence of hypoxia. So hypoxia is very, very important for all patients, any disease for that matter. So oxygen therapy, we need to consider oxygen therapy. So mechanical ventilation consists of two parts, which is oxygenation as well as ventilation. Oxygenation is giving oxygen therapy as a therapy before initiating ventilation, after initiating ventilation. And ventilation is removal of CO2 from the body. So these two components make mechanical ventilation in a more scientific way. So we need to know about the cylinders as it has been taught to me, and as I am teaching my students. What you're seeing in the picture is a dangerous missile if you treat that without much knowledge. So most of us never go behind these cylinders. Most of us handle, the centralized oxygen, but we need to know about these kind of cylinders, how to handle and those things, which was very handy during the COVID times. As I told, everything was made us to realize when there is a dire need. So you need to know about the cylinders. Do not administer 100% oxygen, or do not administer oxygen unnecessarily for any patient for that matter. And always have a target. So when we are treating a patient, when somebody is giving oxygen, most of the times, even in the critical care unit or in the emergency department, I happen to see an order in the case sheet stating that 6 liters of oxygen, nasal oxygen. So that is a plain order I used to see in the case sheet, and the staff nurse somehow they managed to give. So we need to exactly say what is your requirement, what is the patient required. So you need to mention in liters. So ideally, when you are giving an oxygen therapy, you should mention how many liters, through what device, and what is the target for you to step up or step down on the oxygen therapy. For example, oxygen via face mask, a simple face mask, 4 liters per minute, and the target saturation I expect is around 94%. So when that is not achieved, I may have to go for other oxygen modes of therapy. So these are all the various oxygen equipment. So having said about the oxygen therapy for a patient who is breathing adequately and who is presented to you with hypoxia, we have to give supplemental oxygen. So when you have provided supplemental oxygen, but patient is still hypoxic, or when he falls into other criteria for mechanical ventilation, like these things. When patient not breathing, these are all the indications for mechanical ventilation. When patient is completely not breathing, patient is breathing but not enough, patient is breathing enough but still hypoxemic, hypercapnic despite your oxygen therapy, patient is breathing with normal oxygen gas but increased work of breathing, and for patients who is requiring airway protections. So in fact, all the indications for mechanical ventilation will fit into this slide. If you open any standard textbook in emergency medicine, the need for mechanical ventilation will be fitting into the criteria, whatever I have mentioned. So these are all the indications. A patient should fulfill these indications for you to initiate a mechanical ventilation. Right. So now we have confirmed the need for mechanical ventilation. We have identified it is an invasive mechanical ventilation or non-invasive. And we need to do, the next important point is we need to check the connections and circuit. So this photograph was taken by me in the year 2006 when I was working in critical care unit as a registrar. So these are all the important things. So we need to understand what is called a spin index system. So we were taught in such a way, the emergency physicians should be taught about the pin index system to some extent, because we think that oxygen hose doesn't fit into nitrous. That is not so. A pressure or with some connections, even an oxygen hose can go into the nitrous port can go into vacuum. So all these mismatches can happen. So always check your connections before you initiate mechanical ventilation. I would advise, before initiating mechanical ventilation, always check your connections, and all should have a control panel monitoring systems. So Srinath was just mentioning about me as an assessor for QA and other third-party accreditation. So whenever I go for accreditation inspection of emergency department, I make sure that I give this a very important point, whether emergency system has got control of monitoring of gases in their emergency department. So this is very, very important. Right. So the next important after connections and checking the circuit is doing a self-test for the ventilator. We need to check. Of course, there are ventilators which can check on its own. There are still basic ventilators where we need to check the leak, the compliance, resistance, and the sensors. It can be done before connecting to the patient or once in the number of days. For example, every day before use, or ideally in our ICUs, whenever we change the circuit, we do a self-check test. Okay. So again, as I told, the mode selection is based on these three interfaces. The basic principles in mechanical ventilation for any oxygen related issues, we need to adjust what is called as FiO2 and PEEP. So when you adjust FiO2 and PEEP, your oxygen can go up or go down. So any oxygen issues, we have to adjust FiO2 and PEEP. For any carbon dioxide issues, we need to adjust what is called as the tidal volume and the respiratory volume. Whether it is hypo or hypercapnia, we need to adjust only tidal volume and respiratory volume. So we have to remember this basic principle whenever we are handling a patient with on a mechanical ventilator. So as possible, we need to maintain what is called as the spontaneous activity, because not every time we need to give PEEP, we need to give adequate PEEP to maintain spontaneous activity and alveolar recruitment. We need to always monitor and protect and use lung protective strategies. Gone are those days where we use lung protective strategy only for damaged lungs or a patient with ARDS or with bronchial asthma. So lung protective strategy should be used for all patients. I think this is one of the take-home message which I wanted to give it to all of us, all of you who are listening here. So lung protective strategy for all patients on mechanical ventilation. And whenever there is a dysynchrony, we need to check the connections. Do not switch off the alarm before identifying the cause of a dysynchrony and correcting the same. So these are all some of the basic principles we need to look into before we initiate mechanical ventilation. So we have done so far, we have done all these things. We have confirmed the need for indication, invasive or non-invasive. We have checked the connections and circuit. We have done the self-test. We have selected the mode based on the patient, the interface, the machine, and your expertise. And we are going to set what is called as variables. So what is a variable? So these are all some of the variables we used to handle. So without we knowing what exactly it is, we handle those things. So I am going to give a very brief introduction to people who are never used to know what is variables. So variables are must before you handle a patient on mechanical ventilation, because these are all not complex. These are all very easy to understand. Only thing we are not trying to understand. So we leave it to intensivist many times to handle those things. So this should be known by all emergency physicians. So what is a variable? Variable determine the type of mechanical breath. So these are all the sum of the breath. Some of the variables which determine the type of mechanical breath. What is a trigger? Trigger defines when inspiration begins. So whenever there is an inspiration which it begins, we need to adjust the trigger for we to begin an inspiration. Cycling is when defines when inspiration ends. Controlling how delivery of inspiratory gases is controlled. Target defines the size of the mechanical breath and baseline pressure at which the mechanical breaths occur. So these are all some of the variables. So control and the pressure variables. So like how volume and flow goes, based on the pressure, the lungs expand. So this is called as the basic lung parameters. Excuse me. So phase variables. So this is how an inspiration, from inspiration to expiration, expiration to inspiration initiates, and inspiration initiation to inspiration triggers sensitivity, limit which defines inspiration, and cycle which changes from inspiration to expiration, and PEEP defines the size of expiration and the breath. So this is in short about the phase variables and the control variables. As I told in my previous slide, these are all very much essential for you to adjust the mechanical ventilation for a patient. Right, having known about the things, whatever I have taught so far, like the indication, the variables, and the mode, how to initiate using all these variables. So how to select a mode, either it is a complete or a partial support, whether patient requires complete support or a partial support. And whenever you adjust the rate, titrate to carbon dioxide, which is PaCO2, tidal volume ideally should be 6 to 8 ml per kg. And the flow rate, as I mentioned, it is 4 to 8 times of MV, decelerating pattern. 1:2 is the ideal IE ratio, and FiO2 always titrate to PaO2, and PEEP titrate to PaO2 as well as BP. So these are all the setting variables you need to consider before you set up a mechanical ventilation for a patient. Right, so we have done all the quick checklist, whatever we have done. So now, after setting the variables, we need to set the alarms too. So they're all fixed alarms about disconnection oxygen sensor, which comes as a default in any mechanical ventilation, whether it is a basic or an advanced. So whenever there is a disconnection or a sensor problem, there will be fixed alarms. You need to set the alarms for volume, pressure, rate, and apnea. Okay, choice of mode. So few basic take-home points you need to consider before we choose a mode. No mode is superior to another. In patients with ARDS, pressure control ventilation improves oxygenation, but it will not improve the mortality. So that is the reason I have told that no mode is superior to another. Though we use ACMV, which is as per ARDS net study, still pressure support, pressure control ventilation can be used. So another take home point which I need to mention is never use SAMV in your critical care units because it is a most inferior mode for weaning, and there are evidences patient go for critical illness, myopathies and neuropathies when we use SAMV, which increases the length of stay for a patient on the mechanical ventilation as well as the length of stay of a patient in the critical care unit. So never use SAMV. So take home for a mode is you need to select based on the patient, your expertise, your machine, and no mode is superior to another. You can use PCV or ACMV in terms when it comes to ARDS patient, and never use SAMV in your critical care, critically ill patients. Okay, so modes classified based on the support and the degree of the support. So these are all some of the animations which I have used in my books and to make things easier for you. So this is in short about the spontaneous to controlled, where the spontaneous, the rate is by the patient and power is also by the patient. Controlled mechanical ventilation, the rate is by the machine and the power is by the machine. And then there is one mode in between these two, which has been commonly used nowadays, where the rate is by the patient and power is by the patient and by the machine, which is called as the assist volume control mode or AC mode. So there is another mode between assist spontaneous mode and the control mode, which is called as the assist control mode, where the minimum rate is by the machine and the additional rate is by the patient, power is by the machine, which again, as I told, it avoids patient going in for neuropathy, critically induced myoneuropathies, and promotes early weaning of a patient and early discharge from critical care unit to the wards. Okay, so I think I have come to the end of my presentation. This is what I wanted to convey to you all. So in my presentation, I have spoken about the importance of mechanical ventilation for emergency physicians and few basic definitions. History, of course, history is to remember. I have added few important histories and few definitions I have added, and important parameters like when to go in for mechanical ventilation, when to go for or understanding about the variables, when to choose what mode, and what are the necessary requirements for you to choose a ventilatory mode when you come across these patients. I'll be happy to answer. And once again, thank Yashoda Group of Hospitals for the opportunity and Dr. Srinath and his team for giving this wonderful opportunity. Thank you.
Thank you, Dr. Rajadurai. It was a very well thought process what you have made the presentation, and I'm sure that the residents across the country would be benefited because of this lecture. I think there are a few questions. Role of air in ventilatory settings. Hello? Hello, can you hear me, Dr. Rajadurai?
Srinath, tell me please.
Yeah, role of air in ventilator.
Okay, there's no role for air in a patient for mechanical ventilation who requires mechanical ventilation on a long term. For a patient who requires mechanical ventilation for anesthesia purpose or for a short term, instead of giving oxygen, we can replace oxygen with air and other volatiles and nitrous. I mean, not nitrous, air and oxygen. So we can reduce the amount of nitrous or other inhalation by using air, but there is no role for air for a patient who requires long-term mechanical ventilation in critical care.
Any other questions? do we need to consider various waveforms in ED?
So again, definitely waveforms, it is between the numbers and the figures. So whether you can, arrive at a diagnosis by using the numbers, well, it is well and good. But if you can use the waveforms, if you can understand the waveforms, still it is good. In a critical care unit where, we do rapid rounds, we always go by the waveforms. But when we do a detailed rounds, we always go by the numbers. That is in short, the code which we are doing it here.
Thank you, Dr. Rajadurai. There's one more question. What is your ventilator settings in case of a flail chest injury?
There is no special setting in case of flail chest. All you need to do is treat the flail chest accordingly. Waveforms, special setting in case of flail chest. All you need to do is treat the flail chest. I think I'm hearing back what I'm talking.
No, we are hearing you. Don't worry.
So we need to treat the flail chest, and then by using an ICD or other modes, by fixing it. So the treatment of flail chest should be done appropriately, and there is no special setting for flail chest as such. Thank you for that question.
Any other questions, please? I don't see any more questions. If there are any questions by the participants, they can always, there is something. Yeah. What mode to be started in a patient? Once, I think it's a partial question. I think any patient who has been intubated first, what is your preferred mode to be started? That's what I think the question.
So if somebody would have listened,
yeah, I think
probably good. So we need to consider there is no special mode, or you cannot enter or treat a patient with a specific mode in mind before we actually see the patient. So mode has to be selected based on the patient, based on the patient's lung, based on the patient's hemodynamics, based on your expertise, and based on the machine what you have. The mode has to be chosen based on those things. Thank you.
Correct. So I think the resident, see, if you have intubated a patient for a specific condition, that's what Dr. Rajadurai meant. The condition of the patient is important to set a mode of the according to the patient's requirement.
Regarding the ports, I just wanted to update at our facility at Yashoda Hospital Hitec, we have different ports in different shapes so that there is no confusion, and so we don't plug one port into the other. I think you can see the screen.
Yeah. There's one more question. COPD patient, minimum pressure support. I think what is the minimum pressure support you use in a COPD patient?
So for example, if we are using a spontaneous mode, there is no minimum pressure support for a patient who is coming out of the mechanical ventilation, particularly a COPD patient. So you can start with a pressure support of 12 to 15, and based on the patient's scenario, we can increase or decrease. I think you are asking about PEEP, if I'm not mistaken. So minimum PEEP for COPD patients. So as I mentioned, one of the principles of mechanical ventilation, we need to extensively ventilate all the areas. So with the minimum, with the PEEP, which is the minimum PEEP should be 5 and above. There is nothing called as zero PEEP. Many of us will keep zero PEEP for patients with head injury, patients with the COPD. So in fact, now there are ventilators where we cannot reduce PEEP less than 5. So 5 is a minimum PEEP should be given to all patients for ventilating all areas.
Thank you, Dr. Rajadurai. Any further questions? don't think there are any more questions. No problem. If anybody has a question, they can always chat in the Facebook Live. So this particular patient these sessions are always there on the Facebook, and you can always ask questions so that our expertise will answer you back. Thanks for the question, Dr. Satyendra. If the patient is in case of head injury and increased ICP, the ventilator settings, I think.
And then the minimum PEEP should be 5. Never reduce the PEEP to 0 for patients. As I told, now there are ventilators where you cannot reduce a PEEP less than 5. The minimum PEEP for all patients, for all other patients, should be 5 and above.
Thank you. Dr. Raj Ganesh, your question is how to identify leak in a ventilator patient.
Yeah, there will be reduced minute volume, which is we need to look for the minute volume. So when the tidal volume is less, or when you set a tidal volume when it is not delivering, there will be an alarm, and we need to identify what exactly the alarm is for. So when there is, you need to follow the protocol or the pathways for each and everything. So by then, if you follow the pathway, we can identify it is a leak in the ventilator, or sometimes decapping while we are giving nebulization can also cause reduced delivery of minute volume, minute ventilation, where we need to identify and close it accordingly.
Yes. Thank you. I hope Raj Ganesh, you have understood the answer. Thank you. Thank you. As I mentioned, this particular every lecture series is available on the Facebook. So if any of your friends want to see it on the Facebook, if you just type it as Yashoda Hospitals and this lecture series, you can always look into that. All the lecture series are available on the Facebook, so you can always look into the lecture series and type a question there if you want. And our expertise, including the panelist today, Dr. Rajadurai, will come back and answer, or he will send you the answer live. It was a good discussion, and it was always a good one whenever we listen to Dr. Rajadurai. So thank you very much on behalf of Society for Emergency Medicine India, and by Association of NB Accredited Hospitals and Yashoda Group of Hospitals. Our heartful thanks to Professor Dr. M Rajadurai for his time taken out and explaining us about the mechanical ventilation in emergency departments. So see you next week at the same time for a different lecture series. Thank you. Thank you very much.
Thank you very much.
Thank you. Have a nice day.